Okay. Wow, I'm unmuted and I'm up first. Things are getting better here. So what we're going to do today is talk about the first three processes in working on a QI project. And so we're going to take advantage of doing a walkthrough, and that's one of the techniques that you use when you're doing QI. So we're going to learn about doing a walkthrough by actually walking through part of the process here. And this is Tony and I doing this. Next slide, please. We really don't have any conflicts of interest for doing this other than the university gets the money from SOAR and SAMHSA for us doing this, but it doesn't come directly into our pockets. Next slide, please. So after last week's kind of quick, broad overview, we're going to get into a little more details. We'll talk about the first three processes in doing this, which are identifying a key problem, doing the actual walkthrough process, and assembling the change team, which is really important. All of these are actually important, but the change team is really key to your ability to develop a good program and then sustain it. Next slide. So our objectives are pretty straightforward. We're going to teach you how to identify key problems. We're going to teach you how to do a walkthrough. And you'll learn more about assembling your change team. Now, I want to make one point real quick here before we go any further, and that's the term change team. And it's important because what you're looking to do is not just look at data and see how everybody's doing, but actually use that data to inform improvement processes, because there's always something to improve. And so by calling it your change team, you are framing it in that sense that your goal is to improve outcomes and change outcomes. Next slide, please. All right, you're up, Tony.
Right. I'll take over. So these are 9 steps on this particular list. There are actually 10. The 10th one is completion of the project, but these are the methodical, systematic steps that Niatex has developed in their QI process. They're very similar to most QI processes, but today we're going to go through the first 3 as Mark outlined in the objectives. The next time we get together, we'll look more closely at the remaining steps. And the point, as I've said, is of us going over this with you in this fashion is because methodically going through steps like this and reflecting on exactly what you're doing and why you're doing them keeps you focused and keeps you on target to make rapid cycle quality improvement changes. Next slide. So the first step logically is identifying a problem that you want to tackle. And the key problem should not be too large. For example, a problem that we all want to achieve is getting West Virginia off the list of being the #1 overdose per capita state in the nation. But that would be a little difficult for one clinic to to tackle, because we all have to contribute to that. And you don't have, in your clinic at Northwood, have locus of control over every person in the state, nor would you want your problem that you're tackling to be too small. For example, one particular patient's problem. If there are multiple patients you note the same issue, and that could be a key problem. But for one particular patient, that would be more the realm of the treatment team taking care of that patient. So you want to identify a problem that is applicable to your location or your facility, that you have locus of control over, your team members, and that you can find data on. You can actually measure it. Measurement's very important because the interventions you select to make a change, to know if they're working, you have to be able to measure whatever problem you're trying to improve. You want to, and usually someone either comes up with a problem that's somewhere above you, like the C-suite or third-party payers, for example. They may identify a problem or a quality measure. Someone on your team could identify something they're very passionate about and have an idea about improving something, or it can be patients or clients as well. They can be very engaged and bring up an issue that they think perhaps you could work on to improve some key problem. So when you think about the changes that we're going to talk about, because it's going to be interactive in a minute here, we're going to talk about your key problem that you may have or may have not identified yet. But just think about why do you know it's a problem, and what do you want to change? What do you want to accomplish by putting an intervention in to improve whatever measure that you've decided? The key will be to break down that problem into steps and then examine those steps. And Mark is going to talk about that and the walkthrough process in a little bit, and identify weaknesses or holes or areas for improvement in the steps that lead to that measurable problem that you're trying to improve. And I'm mentioning people here and also data here, but again, those are going to be we'll dive into details next time we get together on those particular aspects. But you want to have some kind of idea about the data that you will measure or the people that you think will be on your team, but you'll refine that later in other steps. Next slide. So let's look kind of at an example here. A team might be interested in improving show rates to a first outpatient appointment, and how a clinic might know that's a problem. It could be multiple ways. They could just know they're below the industry standard for show rates or above the industry standard for no show rates. They could have had better show rates 2 or 3 years ago and noticed a declining show rate over the past 24 months. They could, so, that's how they would identify that as a problem. Or the clinician, someone on the team could bring it up. I'm having to come for half an hour every Monday, and I have 2 patients when 12 are scheduled. So someone has identified this as a problem. And you might want to, that might be a little big, the idea of show rates for first appointment. If you have data to break that down into separate components or characteristics of patients, for example, are these no-show rates for discharges from detox? Are they from self-referred call-ins, or are they from referrals from other services? If you can find the data for each of those, you might be able to refine which exact process you want to look at first. And find out if one of those areas is influencing the overall no-show rate. Say, for example, in this clinic, it's their post-discharge from detox. They identified that as the highest no-show rate of the kind of different patient characteristics. So what the team would do, the leader or the executive that's starting this process will look, what is the process from the point of admission to detox through discharge and to the first appointment? That's where you'd want to focus your walkthrough. And again, Mark's going to talk about walkthroughs in a little bit, but you kind of have to have an idea of what the process is to get to the point where you are wanting to improve. So in this example, a change team was assembled, and they came up with interventions like warm handoffs with a member from the receiving team who comes to the floor and meets the patient before discharge. They came up with an idea of giving written information in the hand of the patient, giving specific instructions on date, time, location of where they will be for their first appointment. They gave a option for an intervention of performing a physical walkthrough with the patient. So at the detox, unit. They take the patient, say the clinic is next door where they have outpatient appointments. They walk down with that patient, show him exactly where he'll go to check in and what that whole process will look like on the day of the first appointment. They also came up with the thought of an intervention of calling between the discharge from detox and the first appointment, setting a limited number of days before discharge in the first appointment, and setting up a motivational interviewing appointment in between the scheduled discharge and first regular appointment, where they really focus on dissecting that particular patient's circumstances and identifying what is the primary motivator for why that patient wants to seek treatment and recovery. So that change team, they came up with all those ideas, and their next focus will be to identify just one of them, just one of those ideas or interventions, to see if that one idea can improve their show rate for detox to first appointment. And they decide that by prioritizing as a team and democratically voting on what, as a team, they all believe is the best intervention for this particular problem. So that's basically, then they'll keep those other interventions that they came up with as a team on the list. And if the first intervention doesn't get to the show rates that they want, then they'll go back to the drawing board and pick another one or other ideas that may come up. So with those considerations, those very high level considerations, did you guys at Northwood have thoughts yet on your key problem that you want to look at? And if so, like, how was it identified?
Yeah, it sounds pretty much verbatim from the project we created down here. Basically from detox to the outpatient ambulatory patients, ensuring they make it to their first appointment, making face-to-face contact with them while they're on the crisis stabilization unit, following up with them on day 1, 2, or 3 of titration to see where they're at, how they're feeling, giving them information packets as to who to contact with what extensions, where to be when it comes to IOP programming, medication checks, etc. And then even the motivational interviewing kind of technique that we have right before discharge, go up, just to put a face to the name, because they hear about the MAT team a lot, but they very rarely get to see us in person. So when we go up and we actually make face-to-face contact, it establishes rapport and trust, and it gives them a better, it gives them more motivation to show up for treatment after detox. And that's kind of, we kind of doing exactly what you just said, Tony. So that was pretty good.
And that's interesting. So you're already implementing that right now?
Yes, we've been doing this since I believe October of 2021, and we've seen success rate go up from it was our first meeting with Dr. Hout and a few other guys. We've seen our success rate go from successful detox CSU to outpatient first appointment. It went from 63.4% to 86.9%, rounded it up to 87% success rate. We ran the data pool.
That's fabulous. So tell me again what your steps were, because you did a lot of interventions, it sounded like at one time. Face-to-face visit from the team at the detox, 1 to 3 days titration, you're checking in with the patient. Is that what you said?
Yes. We have the privilege of having our detox or crisis stabilization unit right upstairs, so it's very easily accessible. One of us usually would go up just during their what we call a titration period for clients being initiated onto buprenorphine. We would go up and just check on them because they do a titration to get up to their maintenance dose. So each day, I had the luxury of being put on the nursing report as well to kind of keep up with the medication and how they're handling it and what have you. If there's any issues, I would be able to go up and address them, or someone on our team would be able to go and address them. Tina, being the manager of our department down here, is the head of our program, but the QI initiative is something that we've developed as a team, and we've really put together, and it's showing great results. We recently broke 100 active MAT clients just for our Wheeling clinic, and it's fluctuating back and forth from the 90s to the hundreds, but it's still right on that mark. So we've done pretty good job with when it comes to retention.
That's and so. Why did you pick that problem from the no-show rates from detox to first appointment versus a self-referral patient or a referral from another source or referral from the ER or something like that? Like, how did you know it was a problem?
Yeah, it became a problem whenever we intended on focusing on QI a while back, retention especially, and when we would see these clients up on the crisis stabilization unit, and they wouldn't show up for their first outpatient appointment. Many of them would just come to detox, get put on medication, and then they'd be on their way, and they wouldn't have made really much face-to-face contact with us. So it was really, I think the change was us putting a face to the name of the programs that we run down here, and allowing ourselves the ability to communicate with them just as much as they'd like to. If they needed to talk to us about something, we'd be up there and talk to them. And we focused on that specifically because that's where we saw the biggest decline when it came to numbers. When we pulled the data back in September, October, it showed a massive influx in clients not coming to their first outpatient appointment after release from the CSU. So that's where we pointed our focus.
Okay, good. And the other clinic isn't on, right, Jay? Okay.
No, unfortunately not.
All right, so next slide, please. Mark's going to talk about the walkthrough.
Okay, so the walkthrough. Let me give you a little bit of history about my experience with this. I was thinking back on this, and the real first experience I had doing a walkthrough was the first time I was involved in a medical intervention procedure. Anybody here ever heard about what a WADA test is? WADA? It's a specific test that's done with patients who have epilepsy prior to receiving surgery. And they're going to have surgery on part of the brain, usually on the left side of the brain, to cut out a focus that causes epilepsy. But you want to make sure you don't hurt them ahead of time by taking out this brain tissue. So you do this procedure where a neuroradiologist puts a catheter up through their carotid into their brain, and they squirt just a little bit of sodium amytal in there, which is a barbiturate, and it puts the left side of your brain to sleep. And that way you can see if the person can still talk and function and remember without that part of the brain, so to speak. It's a pretty intense procedure. It's important to do this, much more important than you might think, to make sure that you help and don't hurt somebody. But as somebody who is not a physician, which is me, the first time I was going to be in this procedure room, it was pretty intimidating. And actually, it was the first time at WVU that we'd ever done this procedure per se. All right. So we didn't wing it. Okay. We practiced and we literally did a walkthrough with all the people who were going to be involved a number of times until we're smooth. And the importance of that is that you have a 3-minute window from when they do the injection to get through all the material you have to get through to make sure that they can talk, they don't lose their strength, they can understand and do all this stuff, and you have to get it done. And it's not necessarily in a comfortable environment. It looks like an OR. So getting that right was really important. And the thing that we learned as we practiced this, including the person who was laying down on the table pretending to be the patient, is all the strengths and weaknesses that we could see about how we were actually going to do this procedure. Now, it wasn't perfect because we were not actually in the procedure room, but it was close enough that we could learn ahead of time what the strengths and weaknesses were from every perspective, from our perspective of doing this to the patient's perspective of how we're presenting this information to them as they're laying prone on a table with a catheter in them up into their brain and a barbiturate in them, which is all challenging. So that walkthrough was really enlightening and helped to shape that up and be ready for that procedure. And then we started doing that procedure. I didn't think anything else about it. Whenever we had somebody new to the team, they had to go through that process with us. Fast forward a number of years, now I work for a surgeon, all right? We talked about this a little bit 2 weeks ago. You want a surgeon and that surgical team to work really well together, don't you? You don't want the new person on the team to kind of be thrown into that procedure and not know and understand exactly what to do. And whenever we're doing a new procedure here through the R&I that some of us or all of us haven't done, we do this walkthrough of the procedure. And that means identifying who is responsible for what and who's going to do what and what the timing is and everything, so we all know, and then we practice as we go through this. Who thinks that this is a good idea to do these kind of things ahead of time for a medical procedure? I'm glad when I do them. And I bet the patients are glad also. This is really not that different, all right, than what we're talking about here. When you're doing a walkthrough for a surgical procedure, you're trying to get people ready and comfortable to do it and practice, but you're also trying to identify where the problems are in the system. And if you actually walk through the procedure where you think there is a problem, you are most likely to identify what those problems are. Okay. You walk through it from your perspective, you walk through it from the patient's perspective. But if we just do it from Tina's perspective, what's the problem going to be, Tina?
Well, I'm not going to see the whole process, and I'm not going to have all the knowledge that everybody as a team is going to have, and it's going to be really one-sided.
It absolutely will be. Do you actually schedule appointments yourself and talk with the clients directly and do that scheduling?
I do actually. My clients, I schedule my own clients, yes.
How about for the program as a whole?
No, just mine.
So then, if we're talking about a process that involves scheduling for your patients, that would be good.
Mm-hmm.
But if we're talking about scheduling for another group or another part of the practice, you want somebody actually involved who's doing that so that you can get their perspective and get that feedback from them. Mm-hmm. And you actually want to go through what that process is. What is that phone call like? Do you guys have scripts that you use when you talk to patients?
I know that they have scripts for different parts of the agency that when they ask for a certain service, then there's a script that they go into for that part of the service. Yes.
Okay. Josh, if you had a new employee coming on, would you have them use a script when they're going up and talking to patients for the first time?
I'm not much of a script kind of guy. I'm more of an interpersonal guy. I like to really establish rapport and trust just by making it happen organically. I don't really like to go off of a curriculum or a script. So if it was up to me, I'd just kind of like them to just be themselves unapologetically.
Okay, and so how are they going to know what to go through with that person and what the talking points are and things they need to get done?
Well, I believe that would depend on what the client presents with, what they talk about, what they feel comfortable talking about, and getting to know what the core issue of the actual problem is.
Okay, I'm not talking about a therapy procedure. I'm talking about getting them scheduled to come down and follow through with their outpatient appointment.
In that regard, I know just from personal experience, what we've done, we've allowed we've made face-to-face contact with them, and I guess I don't know if it would be somewhat noticed that like I don't know if it would be a script per se, but it's more so less of a piece of paper that says when your appointments are, what time they are, who they're with, what to expect during those appointments, et cetera, et cetera. So yeah, in that regard, I mean, it would be.
Do you have talking points that you're going to go through with them?
Yes.
You have things that you're going to touch on. And I understand that when you're dealing with a client, a patient, you don't want to read to them from a script when you're doing that face-to-face and doing treatment and getting them engaged, but you have talking points that you're going to go through with them. And that's important. And so if you have a new person who comes on board, how are they going to know what those talking points are? You're going to have to get them familiar with that so they can do that and then present it how they see fit to make sure that they cover those, right?
Makes sense.
Now, let's say you come in from the outside and you haven't done this before. It'd be nice to know what that process was so that you could do that also. But if you think there's a problem with that process, how are you going to know what that process is unless somebody looks at it and walks their way through it also and dissects it, so to speak? Next slide. So, you guys, we already talked about scheduling from detox, right? Do you get external referrals for treatment in MAT as an outpatient?
Yes.
Yes.
What is your show rate for those?
Go to
Roughly.
we ran two different data pools. One was based off of outpatient ambulatory. One was based off of crisis stabilization unit stay. And the outpatient ambulatory, the data for that, when we first ran it, it was running right around 72.3%. It's now up to 90.1%.
Wow, how did that happen?
Engagement, engage a lot of engagement, and a lot of the problems lied within communication as well. A lot of people would receive misinformation regarding like what to expect, and then when they're given that misinformation, that leads to confusion and whatnot, and leads to no shows. So we eliminated that.
So how did you learn that there was misinformation being presented?
Well, it kind of a multitude of ways, I guess you could say, whether it be, clients or, things we would see in different assessments being done. And just we had to kind of make sure that we were following up appropriately instead of just, I like the idea of the warm handoff. I like that a lot because, whenever you have an outpatient ambulatory client come in and say they're coming from another clinic. They come from another clinic and they're already established on their maintenance dose and what have you. So we send them into our phase 1 of our programming here for MAT. And there's a much higher percentage of a much higher percentage of their likelihood of showing up if we interact with them and integrate them into treatment seamlessly. So the communication barrier was a big one that we have as a team developed a way to get over that by basically just, coming together as a team and identifying the barriers there.
You know what that sounds like to me?
No, sir.
The head of the slide there.
Oh, there we go.
So the team got together, they talked about what the process was. You identified what you thought wasn't working, and a key example of that, which was miscommunication. People were hearing things that were not accurate about the program. And so the goal was to correct those inaccuracies so that you can engage the patients better, and that they had a better expectation of what was going to happen and what it was going to be like when they were there. And correct expectations are actually really powerful with any medical intervention and procedure. Many, many years ago, there was a study that was done with general surgical patients, and they took a group of people and they didn't do anything with them. And the other group, they actually told them what it was going to be like when they woke up from the anesthetic and where they were going to be and what they were feeling like. And they told them where they were going to be ahead of time and then what they would feel like afterwards. And they met the people that they were going to be with when they woke up. And what happened to the people that knew all that stuff and had the right expectations? They got discharged from the hospital faster, lower infection rate, and all sorts of things like that. So correcting those miscommunications, those poor expectations is really important. And you just gave a great example of what it is that you do and what the goal is from a walkthrough. What is the problem that you're identifying here and getting the right people on board to do that? So thank you very much for making my job easier.
Yes, sir.
Tony, do you want to add anything about the walkthrough process before we go on to the change team?
No, I don't think so, other than can't ever emphasize the importance of viewing things from the patient's perspective. Super important. Even if you have to physically walk through as if you were a patient, sometimes mapping the flow out is the best, easiest way to do it. But oftentimes there's a lot of misses on things like getting up, sitting down, picking up the phone, going from one place to another, and a lot of wasted steps and time. So as much as you can think what the patient is experiencing and what you as a patient at some point in your life, hopefully more, not a lot of times that you've needed to be a patient and engage with the healthcare system, but reflecting on that and all the times placed on hold and, appointments rescheduled from the provider side, whatever it is, just the patient side is a very important side to consider.
So that's a really good point. I got to do a walkthrough today with one of my patients who was signing up to do a video visit with me. And he got frustrated with the IT people because they were having trouble communicating with him because his brain is not in the best shape. That's the kind of patients I see. So he sent me a message, and so I just called him and helped him walk through that. But oh my God, the process that he had to go through to do that, I forgot because I signed up for it so long ago. It's brutal. It is brutal from the patient's perspective. And if you're challenged with your thinking, it's a nightmare. It really is. So that patient perspective is really important. All right, Jay, next slide.
Okay, so we're going to talk a little bit about a change team, and there's basically the team itself, the change team itself, which we'll get to in a second, but the executive sponsor and the actual change leader. The executive sponsor is someone that has authority, can remove barriers, is supportive, typically doesn't do the implementation work. But if you need something, they can take care of it for you. You want them to have enthusiasm. Oftentimes the problem that you're seeking to solve, the key problem, is identified by the executive sponsor. But again, not necessarily doing the implementation. Now, it really depends on the size of the organization. Sometimes the organizations, the executive sponsor is also the change leader or part of the team. But oftentimes the larger the organization is, the bigger the hierarchy it is, the less likelihood the executive sponsor will be actually in the trenches doing the change work. However, they will need to be kept abreast of the change work during the whole process. And like I said, they will have to have the authority to remove barriers, because that too the change team will go to if they run into problems with, say, IT or medical records or, some other department or division in which they might have some oversight, but the change leader or the other members of the change team might not necessarily be able to influence. Who were one of you, did you guys have an executive sponsor?
We didn't really hand out any titles per se. It was kind of a thing myself, Tina, and Jeremy Sagan were working on for some time. And one night I just kind of, it just got in my head. I was still in my graduate program, so I was still in homework mode. So I just went ahead and created a project. We called it Project Retention. And it didn't really include anything regarding people with titles or what have you. But that's something we can absolutely work on, is actually giving titles to individuals in the change team.
And it doesn't, that's fantastic that you were in school mode and thought of this change process. Did you have to get anybody's approval to do it?
Yeah, well, I created it, and then I gave it to our director of operations, Jeremy Sagan. He looked at it, and then we had a meeting with Dr. Hout and a few of the other ladies and gentlemen on here regarding QI. So it was something that him and I had been talking about for a while, just retention, QI, and how to keep clients, engaged in treatment. That's when we started finding where the holes were. And a lot of those were from the outpatient ambulatory and inpatient detox to outpatient.
So, and theoretically, based on their model, and again, there's fluidity in what, labels you assign to people, but basically whoever the barrier removal is, or the person must give approval, could be considered the executive sponsor. It doesn't necessarily have to be the CEO or the COO of a company, but just one that you would say is in the hierarchy that has the authority to make changes and approve projects. So in theory, Jeremy was likely the sponsor, the executive sponsor. I don't know if he was involved in the actual work. It sounds like you and Tina did actually most of the change work, if I'm understanding what you've done so far correctly. So that's probably how I would label Jeremy. Mark, is there other thoughts about executive sponsor that?
Yeah. So you guys have a small, tight group and you work well together. And some of this seems like a little bit of extra work, it might be. But you want to think about this from the perspective that that may not always be the case. So who makes the decisions for the direction of the overall organization? Who does that?
The overall organization would be Jeremy Sagan, and then it would be Tina Harper, our clinical supervisor down here, manager of the substance abuse department.
Well, that's the substance abuse department. I mean, the whole organization. Who do you guys work for?
That would be our CEO.
Mark Games.
Mark Games, yeah.
Okay. And does he happen to be somebody who's involved and wants to know about these kind of things and what you're doing? Or is he, things are good, more hands off?
I'd say he's more hands-off, gives us a lot of autonomy to let us work. And that actually has proven very effective. The more autonomy we've been given, more freedom to move.
Okay. So imagine you have a new leader come in at some point and they're a little more hands-on and they want to know what you're doing and why. They may not actually want to have to approve it, but they just want to be informed. Or maybe they come to you with something and say, how come so many patients are not showing up for this or whatever it is? I want you to work on that problem. And if they came to you with that, this is a good example of how you want to view that. If you don't have to, you don't have to do it. Don't create extra work for yourself. But if that presents itself, you need to understand that. And you want to think about the change leader as that person who's really going to champion it and be that conduit for the executive sponsor if you need to have that happen. All right. They're the person who's going to pass information back and forth, make sure you get the support, make sure that the changes and barriers are removed if they need to be there. And they're only going to do that if they're involved, understand, and have buy-in from this. So right now you don't need that because of how you guys are working and what the unit is like, but be aware of it in case you need it in the future.
Plus, I would totally brag on your success to your executives, even if you're not involved in the, I mean, you're doing fabulous work. That is really admirable. And it's something that any executive would love to hear, whether they're hands-on or hands-off. It's fabulous work.
Thank you very much.
Because eventually they got to report something to somebody. So give them some good stuff to report. So that's great.
Yep.
You know, the other thing that we need to talk a little bit about is the team itself. And again, you know, if you go to the next slide, Jay, you know, some of this is not necessary for your group, but you want to be aware of it. Because it may be at some point somebody new comes in and you have to bring them in. They have to be part of the team, or somebody from the outside gets involved. So Tony, you want to talk about this a little bit more?
Yeah, so sure. So the change leader is typically someone that either is very passionate about an idea, they're part of the team, and they really, frankly, like Josh, like it sounded like you came this plan, you were in this mode and you thought about a way to improve your patient outcomes, particularly related to show rates from detox. So you were passionate about it. You were part of the workflow, the team. You engaged with Jeremy and other people in your clinic. I'm assuming you're well-liked and competent. You definitely seem so to me. And so again, this person, depending on the size of your organization, and the relationship that the team has, will be someone that other people in the flow of patient care will see as someone that they can admire, they can respect, that will take care of them, that will hear them, and that can coordinate the team as a whole. It would be a good idea to have a good relationship with an executive sponsor if there is such a role, because this change leader will be keeping the executive sponsor abreast of the progress of the project, what the outcomes are, if there are any hiccups or problems that need to be taken care of.
So, Tina, do I remember that is it you guys that have a separate unit that does some QI in other areas? Is that
Yes.
right?
Yes.
All right, so imagine, for whatever reason, somebody from that QI unit is now sent over to be part of you guys' team.
Mhm.
How are you going to address that? What are you going to do about that? Because they probably come with their own perspective on these things. They may or may not understand about substance use.
Mhm.
They may have their own processes for how they do things. What are you guys going to do to make sure that it doesn't impact the team and she becomes part of the team and the team actually learns and adapts and takes in things from her because she does this from a different perspective? It's not having this person come in and just do things your way, but thinking about how to do that. What would you guys do? How would you do it so that they felt good and comfortable as part of a well-integrated, oiled team that's doing great things? So thinking about those things is going to be important, because eventually something like that is going to happen. Because you know what? People come and go, things happen. And so being ready for that is important.
We actually already have sort of a relationship like that with our QI department and the head of the QI department. He interacts with us often to make sure that we're kind of meeting the points that they come from. But we're very fortunate in that he does not understand substance abuse. And he's always asking us, if I need this, how does that fit in? And so, he and I communicate well and often. And so he kind of lets us do what the department needs to do, as long as we're crossing the T's and dotting the I's and doing all of that from his department's perspective. So we're working really well.
So I'm going to give you guys a challenge then, since you presented that. And the challenge is how can you get him a little more involved in what you're doing? Because he's one of the QI guys, right? This is what he knows. How can he teach you or lend some information to you or guidance to you that might improve what you're doing? Because that's what a QI process is. And so it's great that he's letting you guys make the decisions about substance use. But this is different because he has a greater knowledge store about QI processes and what to do and how to do things. And he may have some things that he can teach you guys that will benefit your program and your orientation. So think about that. Does that make sense?
Yeah, absolutely.
Next slide. Tony, you're still up.
And we're at the 5-minute warning before questions.
Oh my God.
The rest of we were worried about filling time. The rest of the change team will include up to 3 to 5 more people. You don't want a change team that's too large, that you can't reach consensus and get things done. You don't want it to be too small, that the work that you need for the intervention cannot be done, or it becomes overwhelming because we all have other responsibilities. Most of us have other responsibilities that we have to take care of. So having a team 3 to 7 people is typically the sweet spot. People will have collective responsibilities, like you will have meetings X number of days or X number of weeks between meetings. And then they will have individual responsibilities as part of the team. And one of the biggest assignments for an individual or a couple individuals is the data collection part, because that can be really difficult if you don't have an electronic health record that you can just extract information from, or some dashboard that shows you the metrics that you're following for your key problem. So assigning someone to be the data person is really important. And then any intervention, obviously in the patient care realm, having someone that actually takes care of patients is important, because you want to see that that intervention is working in that environment. And also, just the last thing I'll throw out about this is that doing the walkthrough, you will often identify, as you look at different projects, you will often identify a person that you never would have thought about being on your change team, but that really should be on your change team, like someone that works at reception, checking people in, or someone, the MA. Oftentimes some people are just left out completely when new processes have started. And number one, you might lose buy-in if they're a really integral part of whatever change you're coming up with or whatever process you're trying to improve. And number two, they're having involvement of a key player like that can often make or break the motivation level of completing successfully a change. Mark, do you want to finish up?
Yeah. Let me give you an example of adding a person that you never would have thought of would have been helpful, but they turn out to actually be helpful. And that would be Jay Mason, actually. So I'm kidding. So look at this last bullet point on this slide. Give a 5x5 presentation, 5 slides in 5 minutes, to be able to kind of hit home to what the idea is, what you're going to do, and how you're going to manage this and implement it. The idea that I would add to that, that's Jay's bullet point there, and it's great, is anybody on the team should be able to do that. All right. Anybody on the team should be able to do most of what's happening in this QI project. And that's for a couple reasons. One is because of the bus problem. What's the bus problem? You walk out the door, you get hit by a bus. Who's going to pick up and do whatever your piece was in there? Everybody's got to know everybody else's job and perspective so that they can chip in. But the other reason is, if anybody can do that 5-minute elevator pitch presentation for this, then everybody on the team has the same level of buy-in for this, don't they? And you really have a cohesive team that is going to work well together and see what's working, be able to call each other when things aren't working, and then figure out the right process to do that. So having a good team is really important. And thinking about anybody being able to step in and do these pieces is really critical for that team working really well together. So think about, if you guys are going to do a presentation later on in this echo, oh, wait a minute, you are going to do a presentation later on in this echo. And you never know, the person who is going to be assigned to talk may not be able to do it that night. It'd be great if somebody could just slide right in there and do it, right? Okay. Last slide. So how did we set up our QI team? Well, we did it the wrong way to start, and then it got better. Sheena and I got together and said, we got to come up with a QI team. And then we started thinking about the right people to have involved and who would be the people that would bring the perspective. And frankly, I think it's really a great team, and everybody adds something to this team and has a really great perspective on it. Whether it's Katie as a therapist, Olivia as the case manager, Tony as a prescriber, et cetera, et cetera, et cetera. Everybody's got a perspective on this that brings to it, that helps us solve these problems and figure it out. And everybody works really well together. And so we appreciate that. So it started small with Sheena and I, but we assembled that team. We got the approval of the executive leader, who was Dr. Barry, as chair of the department. And then we figured out what everybody's role is in doing this, and we're moving forward with this. All right, Jay.
Is this me? Is this Tony?
Yes.
Go ahead, Tony.
Well, this will be the next time we get together in a couple of weeks, looking at the rest of the NIATEC steps, and reviewing what, and most importantly, especially in your case where you have made significant improvements, how to sustain your first QI cycle and what that sustainability plan looks like, because that's just as important as doing the project to begin with and improvements.
What kind of questions do you guys have, since, you know, we got a whole 3 minutes to spare?
I had one question. What week is it that we'll be presenting?
That is a great question. So the next session is on the 7th. That'll be our last kind of didactic session. And so the 21st of February is your first opportunity.